little bit early because this is a Hutzler-Reeves lecture in addition to being one of the Berman Institute bi-weekly seminars. So I'm going to take a little extra time in the introduction, and I want to leave as much time as I can for our speaker and conversation. So let me kick it off. So welcome, first of all, and I want to say twice a year we have the opportunity to host the Sheila Hutzler-Reeves Memorial Lecture in Palliative Care. And Chris's talk today is one of the two for the year. Let me give you a little background about the Reeves lecture. Eleanor Trowbridge, who started and endowed the fund that permits us to host these lectures, was a member of the advisory board of the Berman Institute of Bioethics until she passed away in 2007. She had the foresight to create a fund to allow us to host these lectures, and that bequest permits us to do so. She was very concerned about and committed to the ideas related to palliative care, and so we're pleased that the bequest allows us to hold these sessions in her honor and memory. Ellie Trowbridge was born here in Baltimore. Her father was the president of the family-owned S. Can & Sons department store, which was a downtown landmark in Baltimore from 1893 to 1975. She graduated from Baltimore Friends School, son, and she attended Vassar College and George Washington University. She was quite devoted to Johns Hopkins. In addition to serving on the Berman Institute's board, she chaired the School of Public Health Council on Population and Family Growth. She also worked for many years in development on behalf of Johns Hopkins, most notably related to oncology. And that personal focus took on even a greater significance for her with the death of her daughter, for whom the lectureship is named, Sheila Hutzler-Reeves, who died in 1988 from breast cancer. In 1995, Ellie and her second husband, Alexander Trowbridge, established the Con Trowbridge Fund to provide a fellowship for a student at Johns Hopkins in the Department of Population, Family, and Reproductive Health, and to support faculty research and education projects. In 2003, not terribly long before she passed away, she received the university's Heritage Award for her outstanding service to Johns Hopkins. So we are thankful for that bequest, and as I said, this is one of the two Reeves Memorial Lectureships that we will hold this year. It's my pleasure to introduce our speaker today, who will give one of the Reeves lectures, and that's Chris Feudtner. We had a conversation about how to say his name, which is complicated, I think. I got it right, however. Feud like fight, so that's the way to remember. And Chris is a pediatrician, clinical investigator, and ethicist at the Children's Hospital of Philadelphia, better known to those of us in that world as CHOP. And he's on the faculty at the University of Pennsylvania. He works to improve the lives of children with complex chronic conditions and the help to their families as well. He works on developing clinical programs while also taking care of children and providing palliative care, hence the appropriateness of having him deliver one of the Reeves lectures this year. He lives outside of Philadelphia with his wife, who's also a family physician, 3 children, and 2 dogs, and a partridge in a pear tree or something. Thank you, Chris, for being here. Please help me welcome Chris to give the Reeves lecture.
People all the way in the back hear me? I hadn't really thought about this, but what Jeff said, I took it upon myself when I was a fellow to think about my mission, and I am devoted to taking care of children with complex chronic conditions and their families, including when need be, providing palliative care. And more recently, I've been thinking as to how my career is evolving. I now think of myself mostly as striving to help people confront adversity. And I hadn't put the connection between that and feud, so maybe it was there in my name from the beginning. How to actually tackle things that we would rather not parents and that my research team, my colleagues on our palliative care team, ideas that we have pulled together to think about how people confront adversity. I have no conflict of interest in Claire other than the fact that, like everybody, I have a life to live, and I'm lucky to live it with these people. I want to start out with what I take to be a mysterious observation. And this comes up over and over again. Just so I have a sense, how many of you have ever participated in a palliative care conversation? Okay, so the majority, but not necessarily everybody. What I'm about to recount is not an uncommon occurrence in a palliative care consultation that we do at our children's hospital. This particular case involves a boy who I will call Mason, not his real name. He was 4 years of age when I first heard about him. We had started our palliative care team about a few months before, and we were just getting up and running. When the phone rang at my office, and I picked it up and I said, hello, speaker. They said, we have a palliative care consult we'd like to call in. Are you able to do that potentially? So, sort of surprised and really thrilled that we were starting to have people recognize the service as an offer. I said, I'd be delighted. What's going on? Well, the story as recounted to me by the resident was that Mason had been born a healthy boy after an uneventful pregnancy and went home, no concerns in the newborn period, but had failed to gain weight. And over the course of the first 2 to 3 weeks, that concern went from being just a mild background concern to going to the pediatrician, trying to figure out what was going on. A couple of interventions were done with how he was being fed. He continues to be followed outpatient. And by the time he's 4 weeks of age, people are very worried. Another week or 2 goes by, nothing seems to be working. He is admitted months ago. The initial workup in the hospital had tried to identify, again, the low-hanging fruit, the things that are more easy to identify, but none of the changes in either how he was being fed or the initial diagnostic workup had yielded any clear sense of what the problem was. He had continued to not only not gain weight, but actually was starting to teeter on losing weight, despite the fact that they were pouring calories into him. A week before I got the call, the genetic test that had been sent out, now this is close to 15 years ago, that had been done at the time he was admitted, had come back. Because it was an era of everything being sent out and very long delays. And while they couldn't be sure which of 2 potential metabolic diseases he had, because the gene identification, the defect was not completely characterized, it was down to 1 of 2 potential entities, and both of them were fatal. Family had been given that news a week before. So after hearing all of this, I asked the resident, okay, how can we help you? And he said, well, we're stuck. The family knows that the situation is really bad. We know the situation is really bad, but we can't get him to gain weight. We can't figure out how we could ever get him home, and everybody just seems to be really, really upset, and we're not really sure what. Again, I've been there as a resident. When I say that, I'm not making any comment on what we are capable of, but we get riled up. I said, thank you so much for sharing all of this with me. I can see how difficult this is. Why don't we plan, because I think the next thing we'll need to do is to meet with the family. Could you orchestrate a family meeting? And my team will come and talk with the parents and with your team. So that sounds like a great idea. So the next day, I walk into a room, conference room that was much smaller than this, maybe could have held 14, 15 people. And I go in with Gina Santucci, the nurse practitioner I've had the privilege of working with over the years, Carolyn Long, who was our social worker at that time. The primary medical team is there, and in come the parents, looking as drained, as tired, as sad as you can imagine people ever look. They're accompanied by their parents, the grandparents of Mason, as well as some aunts and uncles of Mason, the brothers and sisters of the parents. So by the time everybody is sitting down, I'm looking at both parents in front of me, and behind them are this host of probably another 8 people. We introduced ourselves. I said early in the conversation, I heard a week ago you got some news. I can't begin to tell you how much I wish that news had been different. As I sit here trying to think of how we, our palliative care team, can help Mason and help you, it will help me if you wouldn't mind sharing with me, given what he's up against, given what you learned a week ago, what are you hoping for? That pause. And the mom said, almost in an explosive, anxious, this weird state that people get in where it's like just spouted out in an exclamation. I'm just hoping this is all a bad dream. I just go to bed every night, I just hope I wake up and the next day like I'm waking up out of this terrible, this has just been terrible. I don't even know what to think anymore. It's just the worst thing ever. Sort of decrescendo there. Thank you for telling me that. I promise you, I heard that, and I promise you I will come back to that. Again, if you don't mind, if you would share with me, is there anything else that you're hoping for? And the mom sort of looked sideways and said, looking at her husband, not really making eye contact, just sort of gauging his presence there. I'm hoping we can stop torturing. Every time they go in to try to draw blood from him, he gets totally wigged out, he gets hysterical, it's so hard to calm him down, and it takes, to get him to calm down again. And then it seems like they have to do something else, and it's just non-stop. I want all of that to stop. I want us to stop doing things that are torturing him. I promise you I'm going to come back. I've heard both of the things that you've said. I just want to make sure we put out on the table so we can look at it, we can talk about everything that you're thinking and that you're hoping. Put it all out on the table, and I promise you we'll come back. Is there anything else you want to share with me that you're hoping for? And for the first time, the father looked up and made eye contact with me, and he said, dead level, I'm hoping we can get the hell out of the hospital. This has been a disaster. It isn't your fault, we understand, but this has just been a disaster, and we need to get over it. But it doesn't seem like there's any way to do that. Okay. Again, I hear that loud and clear, so you've talked about 3 things. I promise you I'll come back. Is there anything else? One of the grandparents leaned in, and then the parent, I think it was the mom, spoke up of a baptism. We're hoping to get him baptized because that was in the works, and then he got caught up in this whole not gaining weight thing, and we all got postponed. Anything else? Want to spend time with the siblings. He had a brother and sister, and they had not spent much time at all, and it was very harried, anxious time at home when he was not gaining weight. So, at the end of that, I had those 5 things that they had shared with me, a few other things. Thank you for sharing all that with me. And Mom, I know the first thing you said was that you were hoping this is all a bad dream. And I can't begin to tell you how much I wish I could make that so. The second thing you told me is that you're hoping we can stop, when you said torturing him, doing things to him that cause pain. And if we decide today, make a couple of decisions, we can stop doing those things. stop today drawing any blood. We can stop waking him up for vital signs. We can stop that if we think through some of what we need to do to take the best, most loving care for him. Is it okay if I just point something out? Parents both nodded. And one thing that I didn't hear you say, I'm just going to say it out loud, is this okay, is that you didn't say that you're hoping he can gain weight. I think the news that you got last week, if we reflect on that, it says to us that he may not be able to gain weight. He may, again, I wish I didn't have to say this, he may never be able to gain weight. But if we just say out loud that we're willing to let go of that hope of him gaining weight, we can stop drawing labs now. And we can also, because I heard you very loud and clear, you want to go home. We could start to make a plan to go home later today. At which point Gina elbowed me, because that was going to be logistically very challenging. But I was in the mood of okay, can we help this child and this family? As luck would have it, we were able to get him home, I think early the next day, because we had a pediatrician who was willing to do home visits. We had a hospice in the area that was devoted to taking care of older patients, but was willing to take on a 4-month-old. And we were able to constitute a team very quickly that could provide Mason with the care that he needed when he went home. He went home, he had a baptism, he had a birthday party, because why not? He had another birthday party with his siblings, because why not? I think they had 4 birthday parties. Spent a lot of time with both his brother and sister, a lot of time with his parents, in the context of their family home, being held, not being lobotomized. And when he died about 2 weeks later, he was being held by both of his parents on their couch. Now, the mysterious part of this is what happened after we had talked about the plan for him going home and how that could unfold, how people left the room. So, as I've told the story to you, this is not a, to put it mildly, happy conversation. I think most of us would think that the conversation would result in deeper depression, sorrow. But when people stood up, as opposed to the inwardly drawn, isolated, utter despairing dysthymia that they had walked in, they stood up, they were crying, but they started to hug each other. And while I don't want to overstate it, they left the room not happy, but purposefully motivated. That they had seen that there was now a way forward. Not to the hope that this was all a bad dream, but to another set of hopes, that if they could pull this off, they felt like perhaps this is what we need to do to be loving parents for Mason, given what he's up against. And what I want to focus on is that change in mood. Again, for those of you who've done palliative care consults, how often have you talked about something that is really hard, and at the end of it, there's a palpable change in the way that people are going to confront the adversity. And it goes from being helpless to a little bit more hopeful. Not about cure, but about we can do something. We will get through this one way or the other. Even if it means that I am going to die, I don't have to do it as a victim, but rather more actively. How many of you have seen that kind of change where it almost becomes a little bit more positive energy if you've done palliative care consults? All right, so what's up with that? That's the whole point of this talk. Because that happens, it is counterculture. Most people think it can't happen, so they're afraid of the conversations. They won't go there. And because they won't go there, this transformation can't happen. One of the things that started me on this journey was passage in Dante's Inferno, which I was reading when I was a fellow out in Seattle where I trained. And there's this passage in the Pinsky translation where Virgil is saying to Dante about the place where Virgil is consigned in the underworld. That here in limbo, we are lost, afflicted only this one way, that having no hope, we live in longing. For some reason, when I came upon that line, I just had this sort of clang association with what it's like to walk into the hospital, a children's hospital, as a parent with an ill child, hoping for a cure. Our child is sick, we're going to take him to this place and they're going to make him better, or her better. And then they get the news that we can't. And a vacuum opens up because nobody is willing to talk about, okay, well, what are we going to do? You just told me what we can't do. And people are left living in this kind of suspended animation of not knowing where to take their longing to be able to do something positive for their child, that having no hope, they live in longing. So, what I want to do in the time that we have is walk through the efforts that we've made to try to understand in a way that we can explain so that we can build upon our notions of what might be happening in these types of situations to provide better decision support for people, families who are confronting incredible adversity. To understand the mechanisms that people employ psychologically, socially, to be able to confront something that's this overwhelming. When we have done this, we have insisted that we need to be studying people in the midst of the crisis. This is Picasso's depiction of the aerial bombardment of the town of Guernica, which was the first time, under the heading of dubious distinctions, a town was bombed from the air by planes. Realize that was not something that occurred before the 20th century. It could not. The first time there's these aerial bombardments, when it happened in Guernica, not only was there carnage, there was also utter bewilderment. What on earth is going on? And when people are confronted with chaos and not just fear, sorrow, anxiety, but also bewilderment, that, in a certain sense, replicates the context in which parents are being asked to make decisions. For those of us who do pediatric medicine, we know about metabolic disease. We know how horrible it is. We can think a little bit at a distance about it because we've seen it lots of times. We've also seen lots of children receive months of care. For a family, it is an overwhelming experience. How are they making sense of that experience as they're going through it for the first time? I'll tell you the answer is not in the left prefrontal cortex, that sort of privileged piece of real estate where everybody who does decision science wants to believe that the best decisions are made in the left prefrontal cortex, where we have our probably location, for the most part, of executive function, higher rational thought. Not that I'm against rational thought or thinking. Me, of all people, to say that I'm against it would be sort of hypocrisy. But it's not the entire answer. In fact, I don't even think it's the majority of the answer as to how people work through decisions. Instead, what they're doing is that they're dealing with their feelings, their affect. And the studies that we have done have tried to understand the influence that affective feelings, and I will say many feelings have with them, merged in with them, thoughts. It's hard to say I'm just angry. You're usually angry about something. It's hard to say that I'm hopeful or I'm joyous. You usually have a target on that makes me joyful. That combination of thought and feeling is very much in play in those types of conversations that we're talking about. And they shape decision making to a degree that I will put out there ethics has been woefully unwilling to tackle. So the propositions I'm going to lay out that we work with over the last decade is that parents don't just think their way the right decision, they have to feel it. How many of you have made a major decision in the last 6 months, a year? Anybody? All right, I'm not going to ask for details. Did you get the Excel spreadsheet out and do a decision analysis? Yeah, exactly. Like it's almost a joke. We make the decisions that matter the most to us personally, often in ways that we'd sort of be a little ashamed to mention, One part gut feeling, one part you try it on for a while and see how it feels, especially if it doesn't have to be done right away. Could I live with this? What would it feel like if I did this? Parents do this all the time. They have to feel their way to the right decision, not just think their way to the right decision. And these feelings are, I'm going to divide them up into two types. There's thoughts about the sick child, which again, ethics tends to think a lot about the patient. But we're dealing with a surrogate decision-making scenario here, where the parent is the surrogate decision-maker, making decisions on behalf of this person who is ill. So the other set of feelings a surrogate is going to have is, how am I doing as that surrogate decision-maker? Am I doing a good job? Am I, Lord forbid, I'm a parent of a sick child, am I a good parent? So what's right for Mason, and what kind of father or mother would I be if I make this type of decision? Again, this is, I think, incredibly important. I'll come back to it repeatedly. And that what we do when we walk in the room, either to do ethics consultation, which I do ethics consults at our hospital, or the palliative care consults that I also do, we are allowing, through the relationships that we build with people, for them to start to think about and feel about how to integrate those thoughts and feelings. And there's specific things that I'll end with that we can potentially do to maximize that. In order to make this memorable, when I walk into a room, I have a mental model, just a schematic in my head. What am I trying to do? Okay. So I walk into a room, and let's say that I'm going to talk to you. Don't worry, I'm not going to ask you anything. But what I'm aware of is that there is a ceiling, a floor, a wall behind you, and a wall where I am standing behind me. The medical bulldozer of knowledge suggests that if you are stuck having a hard time making a decision, I'm going to fire up the engine of the medical bulldozer and just give you more information. In fact, I may repeat the same information you've already heard like 5 times. Most of the time when I go in for an ethics consultation where there's any kind of disagreement between the care providers and the family, there often will have been multiple efforts to educate the family as to why what the healthcare team is proposing is such a good idea. And the parents just don't get it. They don't seem to be getting it. So let's just go do that again. And 9 times out of 10, when I walk in the room, the parents totally get it. They can actually recite back to me with great fidelity what they have been told. They may not agree with it. They may have some alternative interpretations or extra data. But what I want to emphasize is that much of decision-making is about the provision of information. And I'm going to put out there the idea that you have to turn the bulldozer on idle, maybe just let it sit there, or even get it to back off a little bit. Pushing people towards making decisions with more medical information. If it will work early. And if it won't work, it will never work. So what else is there? Well, one of the things that I illustrated in the case of Mason is that when you're making a decision, you're not just being constrained by what's pushing behind you. You need to know where you might go. What is the path ahead of you? So as I am talking about hopes, can I be pushing back this wall so that you start to see there's more space back here than you might imagine? Or to put it differently, you have a notion, but maybe you haven't had the opportunity to explore what it would look like to keep going in that direction, of moving forward towards hopes and goals. Why you may not have done that is because we have fears and anxieties that are pressing down on us, like pit in the pendulum. We're in a room that is getting increasingly constrained. And what happens when, I think, human beings are under this kind of pressure is that they start to lose the ability to think and feel, and they just start to hunker down. So when I ask people, would you mind sharing with me what scares you the most? I am purposely trying to start to say, you don't have to bear that weight alone. There are others around you who will help you start to handle some of this oppressive set of fears, anxiety, worries, sadness, even anger. And underneath us, there are notions that people have about what they need to do to be a good parent. What is the foundation on which I'm standing to potentially push against my fears and anxieties? Where am I trying to go, and who am I trying to be, are questions that need to be brought into the dialogue. All right, so lickety split, we're going to go through some data that supports some, not all, the notions. This is a hybrid model, part data informed by practice. We did studies back in the mid-2000s, 50 children receiving palliative care, 73 parents. And we followed them up. So today is April 10th. Let's say there are 73 parents that I interview. We're now going to follow your child for the next 6 months, all the way through to, I don't know, October, whatever 6 months is from now. And what we're going to see is whether your child who is followed by palliative care but currently does not have a DNR, how many of you are going to put in place a DNR order? And the notion is that we're going to look at hopeful patterns of thinking, this do not resuscitate order, hopeful patterns of thinking, as well as thoughts about how the child is doing, and emotions. Today, can I predict, based on how you are feeling today, what kind of decision you might make? You can read about this study. Things that we found, our parents had very, very high levels of negative affect compared to other groups that have been studied. No surprise, their children are receiving palliative care. They also had remarkably high levels of positive affect, positive feelings. All right, everybody saw that coming, right? One of the great things about doing research is it does give you the chance to run up against reality. This has come up repeatedly in other studies we have done. Again, it confounds the notion that we have that Mason's parents filing in have nothing but sad feelings and negative feelings. What's the positive feeling coming from? What's up with that? Any ideas? Okay, I'll need people to shout out because I'm hard of hearing.
Resilience.
Okay, resilience. Resilience in what way? What's giving them the positive feeling?
They have to have something to counter their negative affect.
Okay.
Recognize it.
Right. So this would be the, I need to, like in Spinal Tap, where it goes up to 11. If I've got that much negative affect, I need to counterbalance it. We'll come back to that idea, because I think it's real truth. But what might be the positive energy pump?
Family support.
What's that?
Family support.
Family support. So they may say, oh my God, I have realized how much my parents and my uncles and aunts, they are the world. I can't believe how much they've rallied around me. That is incredibly important to me.
Even in really bad days, there's often moments of seeing your child feeling a little better, or getting a smile, or some break in the sense of constant negativity, and that connection and seeing that can be incredibly reaffirming and help parents.
And oh my God, it's so precious.
Yeah.
Oh my God, that is like, I live for that smile. I live for when he appears to be calmly asleep, or if they're not in Mason state, where there may be a conversation, there may be an interaction that is, I have a love angel in the room called my child. Do not take that away from me. Okay? So part of what I realize when I walk into a room with regard to the resilience and everything else, being a parent of a seriously ill, critically ill child, I have a potty mouth, I'm being recorded. I won't say what I would typically say. I'm going to bite my tongue right now, but it's not pleasant. It is really, really hard. They have to cope. They have to get up every day, and at some point in the day, brush their teeth. Like, it is hard to figure out how they basically do basic, hygiene. I've had parents who joke with me at 3 in the afternoon, I walk in, they're coming out of the shower. It's the first time I've had a break all day that I could step in the shower for 10 minutes. I still haven't left the room because I haven't eaten anything because I can't. They live for those positive interactions. And one of the things that, again, in the bulldozer model, I cannot take away the preciousness of those positive interactions. So they're walking on a tightrope, and I have to walk with them with one of these very long poles that allows us to balance the positive and the negative affect that's in the room. And what you will see in talking with parents is they're often oscillating back and forth. They're not steady state sad. Even in the conversation we had with Mason's family, it is not uncommon, I can't recall that conversation particularly, but where we will have a conference with a family and it will be very somber and people will be walking by the room and then they'll come back to me later. I heard them laughing in there. What was that about? As though it is a violation of the rules to have any levity or positive affect in a serious news conversation. Now, trust me, I'm not about overselling this, but it's a psychological reality that we see over and over again about the need to respect and to essentially have good fiduciary duty that you're going to take care of that positive regard. It can't become all negative. These are called spaghetti plots. That's my informal name. It's the data of every single patient. Now, to make it clear, I'm going to step away from the mic for a second just to say, what we asked the parent to do today, a week ago, a month ago, 6 months ago, a year ago, worst case health, best case health, how has your child done over the last year? One of the things we see are trajectories, so this, every line is a given patient, where there is tremendous crisis and recovery, this fluctuating course. Okay. In palliative care, we're increasingly aware, we've been aware about it in pediatrics for a while. In the adult world, not everybody goes on a roller coaster ride of just mounting symptoms and steady decline. Congestive heart failure, COPD, many conditions have an undulating crisis and recovery pattern. What we do see, splitting up the cohort based on the outcome that we learned 6 months later, is whether they did not limit of intervention order, a DNR plus other possible not coming back to the hospital, or they did, both groups saw their child's overall health declining, but the decline was a little bit steeper amongst the parents who wound up putting in a limit of intervention. This would be basically saying, I'm aware that the situation is pushing us forward. He is more ill. He is more ill. And this is today. We're talking about what's going to happen in the next 6 months. This isn't even about a decision made today. They just saw that the trajectory over the last year has been downward. Let me introduce hopes into the mix then. I got interested in hope because parents talk about it a lot. It has subsequently become very sloganized, used in ad campaigns, etc., but it is part of our natural language. How many of you had any plans for the upcoming weekend? Goals and objectives for the upcoming week? Yeah, okay. So if I can gently pick on, like, the people who say, yeah, I have goals and objectives for the upcoming weekend, they're like me, like nerds. People don't say that. What they say is, well, I'm hoping we can do this or that. I'm hoping we can get out to the, in the gardening. I'm hoping I can run some errands, see my kids. We talk about hopes as a way of talking about goals and aspirations. Now, in the Western canon, hopes have a mixed reputation. In the myth of Pandora and her jar, there's ambivalent views. If you're Greek, you believe that the last thing let out, hope, was actually the worst. It is the thing that deludes us into persisting when in fact we should stop. It is false hope. The Roman version is more, it's the salvation. And I think that we have tended to romanticize our notions of hope. But there are people in decision science who very much are Greek in the way that they look at it. When I first started to think seriously, can I study hope, I was told by an advisor of mine who I still respect deeply, he said, don't study hope. Hope is the enemy. Because to him, it really only means the non-rational, potentially false hope. It is too emotional. In all due respect, I've attended, but I did not heed that advice. I turned to psychologist Rick Snyder, who had studied hope, and he basically had a model where if you have a hope to, say, leave this room to go outside to get a breath of fresh air, you would have a goal, and then your degree to hopeful patterns of thinking would be whether you could think of ways to do it, your pathways. I could leave by that window, I could leave by that back door over there. Lord forbid there was a fire out there, I could smash one of the windows and we could jump out. We could potentially crawl up through the ventilation duct. Okay. I'm not saying they're all good pathways, but there are people who can come up with a lot of ways of thinking about handling adversity. And then there's the set of thoughts about whether I'm the kind of person who could pull that off. So I can walk out of the building, but I might be afraid of heights. I know somebody else could do it, I just can't do it, even though it's not that high off the ground, I can't do that. Or I'm claustrophobic, I just cannot go up into any kind of ductwork to get out. In palliative care, we are the purveyors of pathway thoughts and agency thoughts. We give people, like Mason's father, who thought there was no way to go home. There is a way to go home. I'll tell you the pathway. This is what it looks like. If it's okay, I'm just going to be straightforward. Have you heard about hospice? It would mean that we would not be checking labs. It would mean that we could decide whether we want to continue to tube feed or we don't. That's the pathway. The agency is, oh my God, I can't handle this. You're going to have people supporting you. You'll have the people I've talked about in hospice, your primary pediatrician who you've known with the other kids for a while. Our team will be available 24/7. We will support you. In palliative care, we are giving people pathway and agency thoughts to help them confront adversity. Our parents, using a tool that Rick had developed, had roughly equivalent amounts of hopeful patterns of thinking compared to nurses in our hospital right above, which this is a trait, psychological endowment, so it's not surprising. They have the capacity for hopeful patterns of thinking. So the question then, to sort of go back to my mentor advisor's lament that hope is the enemy, are people with higher levels of hope more likely or less likely to put in a DNR order? I think a lot of people would have presumed that if you've got hope, you're not going to put in a DNR order. That wasn't what I had seen in practice. I had often seen that the people who became the most, for want of a better word, I'm just going to say stuck. They may have said rightfully stubborn. And there definitely are people who have proved that they were right about that stance. Often do not have a great deal of hope. They are holding on for dear life. What we found is that if you account for how parents think their child is doing, and their degree of positive affect, which tends to diminish the likelihood they're going to put in a DNR, their negative affect, which increases it, the people with the highest level of hopeful pattern of thinking, this ability to look at a situation and then be able to start to generate hopes about how they would pathways and a sense that they could do it to work with that situation, the more they had that ability, the more likely they were to put in a limit of intervention. But there's more to the story. Parents aren't just thinking about what's right to do for the child, they're also asking themselves what should they do. It's not just the kid, it's also the parent. I hope that I can be a good parent for my own child. So we studied this in a more recent study we did at the end of the aughts and into this decade, where we had 200 parents of 158 kids. And at baseline, which is the only part of this that I want to talk about, we asked them through an interview process, what do you feel on the inside you need to do to be a good parent? Again, if you want, you can read about this. With Pam Hines, who's a wonderful colleague of mine now at DC Children's, there was a list that we had come up with, Pam had done very focused work with focus groups and interviews about what parents felt that they needed to do. And I had amassed a lot of interviews with parents talking about the challenges for themselves in making decisions. And this was the list that came out of that work, of what parents often said they felt that they needed to do. I need to advocate for my child. I need to focus on my child having as long a life as possible, my child's comfort, health, quality of life, spiritual well-being. I need to keep a positive outlook. I need to keep a realistic outlook. I need to make informed decisions. I need to make sure my child feels loved. I need to put my child's needs above my own. I need to stay at my child's side. Okay? Now, in this audience, which of these would you pick? I'm not going to go through how we did it. Parents were able to effectively sort these items so that we were able to come up with ratings of how important they felt that they were to them. But for you, what would you pick as your number one item?
Make sure my child feels loved.
Make sure my child feels loved.
Comfort.
Comfort. Anybody else?
At my child's side.
At my child's side? Okay, now you're
I'm double
you have
dipping.
2 things, okay. Anybody else? Come on.
Quality of life.
What's that?
Quality of life.
Quality of life? Anybody else?
I think my honest answer is having the child feel loved, but a part of me is thinking being an advocate, because nobody's going to be as strong an advocate for my child as I will be.
Yeah, yeah. So, key point, these are all fabulous answers. I'm wondering how much in the room people are feeling like, okay, can I guess the right answer? There is no right answer. I can't emphasize this enough. People, when I talk about this work, are like, oh, that comes off so judgy. I'm like, you don't even begin to understand the self-inflicted judgments parents make about themselves. This is not judging. This is what does it mean for you on the inside? What personal sense of duty or standard are you trying to operate by? So when I do the big reveal here that overall, parents rated making sure my child feels loved as the most important, the key point I want to make here is not that. It's the range. This is the 75th percentile, any one of the boxes, and this is the range of what people are saying. So there are parents for whom child feels loved is the top. The lowest, quote, rated item of safeguarding my child's spiritual well-being was, for some people, the most important. The point that I want to make, for those of you who are in the business of actually going into rooms and talking to parents, is have you ever asked them this question? Because I am not a mind reader. I can't walk into a room and know, okay, you're going to be about love. You're actually debating what to do. Because you know that you have different roles, and you're not debating. You're all about comfort. Why are you not the love guy? And maybe you're the advocate, and I can't tell, but I can ask. As I like to say, the secret process that I follow is I ask questions. Because I have learned that parents think about this in a variety of ways. What do I need to do to be the best parent I can be in a situation that is bewildering to me? So, as I recap, and we do the last couple of minutes here, with some time for questions, I think what our work overall heads in the direction is that emotions and hopeful patterns of thinking influence parental decision-making. In the cohort study, these were strong influences, and it wasn't just the thoughts about the child, it was this integrated sense of feelings and hopeful patterns of thinking. And parents have different sense of what they need to do to be a good parent, so much so that maybe that should become part of our routine decision support. So the practice recommendations, there are many of them, but I'll spend more on some than others. The first, if we really are going to try to enter into this emotionally laden space of providing support as people are trying to sort through what the heck is going on and how am I going to think about what's best for my child and what I need to do. I need an invitation. Or as I've come to think about it, this has to be consensual. I need consent. I am not entitled to walk into a room and just, without any negotiation, assume that somebody is going to want to enter into what might be one of the most intimate conversations they are ever going to have. How can I be helpful? Is it okay if I ask a question? So, for those of you who are looking for like technique, is it okay if I ask you a question? Okay, he just nodded. If I say that, is the question going to be like a softball and easy, or is it likely to be a little bit hard? Probably a little bit hard. That's why I asked. So I've done two things with that technique. One is I've given a warning shot. I'm about to take this conversation into a new place. And two, you agreed that it's okay for me to ask. If you had said, not today, I'm fried, too much going on, I can beat a retreat, and I'm totally fine with that. It wasn't going to work anyway, so my colleague, oh, you just have to have the conversation. Good luck with that. If the person is not ready, I need to get permission. I offer promises. When I first meet parents, if I'm going to spend any time working with them, taking care of their child, I will tell them, you don't know me yet. A few things to know about me. I'm very straightforward. I'll tell you what I'm thinking. If I'm worried, I'll tell you how worried I am. If I'm very worried, I promise you I'll tell you. And if I'm not worried, I'll tell you I'm not that worried. And I'm not going to make a promise I can't be sure to keep. Now, I've done this for over a decade. I've yet to have a parent who says, whoa, 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 whoa. I don't want that. Please prevaricate, beat around the bush, tell me some euphemisms. Typically what I get, and it's striking, about half the time what somebody will say is that's exactly what we want. Particularly the men, the fathers. That's exactly what we want. I get it from moms as well, but I think that there's a kind of rule of straightforwardness. But it has to be consensual. So once I have said that, and they've said, okay, then I can go back later. I promised you that I would be straightforward. So I'm just going to say this in a straightforward manner. I wish the news was different, but the therapy we started the day I came on, if that was going to work, it should have worked by now. 3 days later, I think we have to declare that therapy is done. It's not going to work. And trust me, there are many variations on how to basically go back and remind people, I promised you I would behave in a particular way. And why is that important? Because it sets the feeling tone in the room back to, we are in this together. I am not trying to push you forward with a bulldozer. I am here in a space that I'm trying to keep it open as much as we can. But we do have this common problem that something didn't work, or something has come back that's bad. In this together. As we discuss the hopes behind me and the fears, I've already shown you some of the techniques. Given what your child is up against, what are you hoping for? I'd like to emphasize that what the mom said, what Mason's mom said at the beginning, is so common. I've come to think of it as the miracle hope or the lead hope. I also think of it as a parental duty hope. How many of you are parents? How many of you would not say, if somebody asked you, what are you hoping for, the first thing that would come out of your mouth, I'm hoping he can be cured. I hope he can live a long, happy life. I would be willing to be in the bed in place of him and know that I was going to die if he could live. Because what kind of parent wouldn't hope for those things? Now, when we go into rooms, I often will talk to my colleagues, if I'm going in with one of the specialists, about, I'm going to try to see whether they want to talk about the hopes, and if they do, just calm down. The first thing they're likely to say, you will react to, is being unrealistic. Don't. Treat it with great respect and empathy. They need to say it. As I did in the example, I acknowledge that I've heard it. I can tell them with utter sincerity, I wish I could make that happen. I do not need to refute it. about half the time when I go in with a specialist, that first hope, oh, well, wait a second, I showed you the scans last week, and we're not able to do that. It just misunderstands the dynamic of thinking and feeling. This is not about medical information. This is about an expression of what they feel that they need to do to be a good parent. That sense of what they need to do, you can ask the question. So again, if I were working with you, one of you who answered. You know, I've taken care of a lot of children who've been very ill over the years, and I've learned that parents often have an inner sense of what they need to do to be a good parent. What are you feeling you need to do on the inside? And if you told me it's, I need to make sure my child feels loved, or you had said it, we could talk, well, what will you need to do that? Because I want to support you in being able to do that. And you may say, I've got it all sussed out, I'm totally fine. When people often say, I need to stay at my child's side, that reveals a conflict that they're struggling with, how to live up to that. This making good medical decisions, how can we help you with that? Your child's comfort, what will that look like? And I have found that this question opens up a whole new domain to talk about how I can ally with the parent in their confronting the adversity. Not just of what's best for the kid, but how I can help the parent do what is best for the child. I think you now see how this model starts to work together as a more integrated way of thinking about decision support, not just as information, but also a set of feelings that have to be sorted through, worked through, and that relationships enable you to increase the space, the breathing room that people have to start to be able to look at the situation, to get grounded, to figure out, okay, how do we move forward? All of that to say that we're managing emotions, very strong emotions, these mixed emotions that are very key to being a good parent. In fact, in pediatrics, people get a little worried if the parent isn't intensely emotionally connected to the child. One of the things that I have felt for myself is I need to be utterly authentic when I am in that space. I'm not wearing a tie today because I don't wear a tie. I need to be authentic even when I'm talking to you. I just don't do that. I won't be wearing a jacket, so I made one concession. But in a room, I am there with the family. And if I walked into rooms and they were wearing ties and jackets, maybe I would, but they're not. I just walk into the room. I am Dr. Feudtner, although what should we call you? Dr. Chris is fine. And I'm fine just being Chris when I'm doing decision support. I may know a lot, but that's probably not where the work needs to be done. The work probably needs to be done at more of this relational level. And if we name some of the things that are going on, we are probably going to be able to better manage it. To do that, I have to be managing my own emotions. I could talk about this at length. I'm not. Of how to be the calmest person in the room. We work a lot with our fellows on this. And all of this is aiming towards potentially helping people re-goal, which is a concept we've written about. Most of us don't think about how we change plans all the time. And what is the psychology that enables people to let go of one goal and pursue another? In the end, what we're also helping people do is to weave a story where they can understand the role that they're playing in their child's life, for however long that life goes on, that they are loving parents, or devoted parents, or strong advocates, whatever it is that they need to, because 99 times out of 100, I can completely endorse how parents are responding towards not just making sense of their place in the narrative, but advocating for their child, taking wonderful care of their child. So, what do emotions, hope, love, relationships have to do with medical decision making? A lot more than we've acknowledged. And best practices for decision support have to deal with that reality of parental love and duties, as well as our own personal sense of commitments and duties. And partnering relationships is one way that we can move forward. Thank you.
We were really, unfortunately, short of time. That was a great talk, Dr. Chris. I guess I should call you that. That guy with the coat and the tie on. Maybe what we can do is one question, but you have to pick who.
I'll be very short. one hand, so it makes my choice easy.
I'm not a
Please,
health,
please use the microphone so we can all hear it at the table.
I'm not a healthcare practitioner, but your talk engaged me thoroughly. I'm curious about your views of how far the medical profession has come, where it is with regard to the things you taught us about today.
So I am in love with the generation that is coming up through the ranks. They are heartfelt, particularly in pediatrics. I can't speak to other areas of medicine, I don't swim in them. They are heartfelt, they are socially oriented. What we lack is the skill set. Because this is the kind of skill set that you often don't get taught, you don't see necessarily in the day-to-day practice, so you don't necessarily build the skills. So when I'm working with the younger generation as they are migrating up, I talk about don't practice this at the deep end of the pool. Try this out with a little baby who's coming in for a very curable bronchiolitis. In fact, you probably don't even need to admit the kid, but we'll admit them anyway, give them some oxygen. And what are you hoping for out of this admission? I promise you that I will be straightforward. So I try to get the junior trainees to realize that you don't need to start when we are totally wound up because, oh my God, it's life and death. Practice this engagement, this way of collaborating with parents in situations which are not life and death until you start to get your sea legs under you. How do I ride this back and forth? How do I engage with the family? How do I potentially think about what they're worried about, what they're hoping for, what the medical information is, which is where everybody's so fixated. Relax on that a bit and explore what they think they need to do. So we're moving in the right direction. We do have obstacles, and I think the time ahead can potentially be very challenging with payment reform and other things, because this work does take time, but I remain optimistic.
Thank you, Chris. Let's all join in thanking